Welcome to session 4 of day 3 of Rhythm Intervention Online 2021. I'm Richard Schilling from St Bart's Hospital, broadcasting from the Rio studios at Welbeck Heart Health in London. We're back with a live case from my own hospital at Bart's, and it's a PVI with substrate modification in persistent AF, performed by my friend and colleague Ross Hunter. But before we join them, I'd like to introduce you to our esteemed panel. Hugh Calkins from Johns Hopkins in Baltimore, the US. Hi, Hugh. We've got Aldo Rinaldi from Guy's and Thomas's Hospital in London. Hi, Aldo.
Hi, Richard.
And Jan Steffel from University Hospital in Zurich in Switzerland. Hi, Jan.
Hey, Richard. Good to see you.
Great. So remember, audience, we're live, so do keep submitting the questions for our panel. It saves me a lot of work of having to think of questions. And without further delay, let's hand over to our live case operator, Ross Hunter.
Hello, it's Ross Hunt here from Bart's Hospital. Hello, Richard and the panel. Are you guys hearing me okay? Hello, everybody.
Yep,
Shall I give you a little summary
There's always going to be a bit of delay.
And where we're up to? I see, yeah, okay. Shall I give you a little summary of the case and where we're up to so far? So we've got a 70-year-old gentleman with persistent AF for about 15 months. He's failed a previous cardioversion, and he's been back in persistent AF for about 6 months following that. He's not tolerated beta blockers and is just on some calcium channel blockers and anticoagulation. Got a previous history of coronary disease, but with normal left ventricle. He's got a moderately dilated left atrium, but otherwise a fairly normal heart structurally. So this case is under local anesthetic and sedation. And it's using the new EnSite system. So we're lucky enough to have that, and we're using some examples of omnipolar mapping, which we'll show you, and the HD grid. So I was looking at the program, and I think you've had lots of talks about this just yesterday, have you?
Yeah, so where are you up to so far, Ross? What have you done so far for us?
Okay, so I've put 3 sheaths at the right femoral vein. We use ultrasound guidance for that here. The CS was fighting me, so we've taken an SL3 for that. I've got a decapolar catheter in the CS to show us some activations. I'll show you the electrograms in a second. We've got a SL1, and we've used a BRK and a safe sept to do the transeptal, just with fluoroscopy guidance. And I've passed a MAP catheter with a medium curler Gillis alongside that. So we've just done a geometry, and with that I've done a voltage map. Should we switch to the voltage map? So I'll see if we can show you the voltage map here. So this is the geometry using the new EnSite system. Looks very similar to what you might see with other systems. What you can see is a voltage map which looks about representative of what we thought we saw on the way around, which is a bit of scarring on the anterior wall and the roof. The system's got an algorithm for picking out areas of fractionation, which it shows up as the white balls there. So it's not quite the old cafe mean map that you would have seen previously, but it's similar. Okay. So that's where we're up to at the moment. We're just doing isolation of the left pulmonary veins. It's actually going fairly well, and the HD grid seems to have gone fairly quiet already. Which perhaps says something about the scarring in the anterior left atrium. Are you hearing this okay?
And Ross, if you got isolation without completing the line,
Yeah.
would you still continue to complete the wide encirclement?
I do really. I suppose I think of it much like the closed protocol, I suppose, that Duchaiva's bunch has made famous. And really, I try to do that. I try to work my way around, have contiguous lesions, and not leave any gaps. Yeah. And if it isolates, I would still try and finish my line. I know it's very different to what we used to do maybe 5 years ago, which is, yeah.
While you're carrying on with that, let me ask the panel, maybe starting with Hugh. Hugh, what at the moment do you do beyond pulmonary vein isolation in these patients with persistent AF?
My approach currently is for a first procedure, I'll just isolate the veins. And then if they need a second procedure, with a second procedure, I'll re-isolate the veins. If they're reconnected, I'll do a wider area circumferential ablation and also ablate the posterior wall with a series of 3 linear lines in the posterior wall, but making sure that all the electrograms are gone. But for the first procedure, you get a lot of patients, one procedure is all they need. And I'd like to stay away from the posterior wall because of the atrial esophageal concern. So I use that currently for second procedures. So about, whatever, 20, 30% of patients need a second procedure, but overall it seems to work well.
And Aldo, what about you? What's your approach to these patients?
Well, Richard, I think it's very similar to what Dr. Calkins has just said. For the first time, I think pulmonary vein isolation for these patients. And if the patient represents, then if there's clear reconnection of the veins, re-isolation, and often we will do a substrate map if there's scar within the left atrium, then consider posterior box in these patients. But for the first time round, we usually, myself, PVI.
And Jan, it's quite interesting that many people are now just isolating the veins. Are there any people that you would do more than just isolate the pulmonary veins?
Yeah, kind of hard to find the data for that, right? I mean, with everything we've tried so far, we've failed. So I think PVI ultimately, even for a persistent, long-standing persistent, even would still probably be mainstay. Although I would agree that I would, especially in these patients, try and do a voltage map. Obviously, that's a bit difficult when you're going for a single-shot device like cryoballoon or PVAC or something like that. But to have an idea also for risk stratification, not necessarily to do for the lesions, but also for risk stratification in case there is a redo in these patients. But no, I'll do precisely as Hugh and Aldo were saying, primary PVI.
Richard, could I ask a question? I mean, I wasn't sure Ross could hear me. He said that the patient was being done in the local anesthesia, non-GA. Is that right? Is that
Yeah, that's right. Yeah.
Can you maybe
It's very much the norm here, really. Yeah.
So what are you giving the
Sorry,
patient?
you're cutting in that a little for me. So he's snoring just a little bit right now. And he's had 3 milligrams of diamorph, 1 imidaz. So it hasn't taken an awful lot. I suppose it does get to be a problem sometimes if people are over-sedated, particularly with benzodiazepines. They can get a little bit agitated. So I suppose a careful balance. But I mean, this gent's doing very well. I think his BMI is somewhere in the low 30s. I think he's of average height and about 100 kilos. So you can see a little bit of respiratory swing there going with his snoring. But even still, things seem to be going okay.
And is your use of sedation, do you use sedation because you don't have ready access to general anesthesia, or do you think it's a preferable approach?
I think in the UK there is a problem with access to general anesthesia. I think we do something like, well, pre-COVID we were doing almost 1,000 AF ablations a year, and we just don't have the anaesthetist to keep up with doing all that under general anaesthetic. And I suppose giving propofol as a cardiologist is not really accepted in the UK, rightly or wrongly. So I suppose in the UK it's very much a case of you would either proceed and do them under sedation, or you would just not have your AF ablation, is the truth. And to be honest, we got so used to doing it, it seems to work pretty well.
And Ross, can I ask a question? How do you get around the issue of excluding left atrial appendage thrombus? Do you still do a TOE in these patients if they're under sedation, or and do you use guidance to try and
so I suppose it's case by case at the moment. Yeah, so for people without elevated CHA2DS2-VASc scores, we perceive that the risk of thrombus is very low if they're adequately anticoagulated, so following the standard rules of having had at least 3 weeks beforehand. For people with particularly high risk, it's still up to us whether we want to TOE them. And if we were going to do that, we would just do it at the start of the procedure, again under sedation.
So
I suppose we still do that with people with particularly high
using?
CHA2DS2-VASc scores or stroke.
Yeah, we've switched
I'm using
to
45 watts, and I'm being guided using our LSI.
Sorry, you go
So
ahead.
what was that last bit?
No, we've made a shift with COVID. It was hard to get TEs done, so we started using CT, and now we've shifted completely to using CT to screen the appendage before every AFib ablation. And between that and uninterrupted NOACs, touch wood, there's been no strokes. It's been a great workflow.
Yeah, absolutely. As a matter of fact, we've started that about 6 years ago, mainly to just get more because we had a problem with TOE access in our own hospital. So we started that about 5-6 years ago, and it's actually when you talk to the CT guys, they feel that they're actually the gold standard that everybody else has to measure themselves against. So while we were doing. While we were doing CT anyways for merge procedures, we kind of got two birds with one stone. So we used that to exclude the appendage with a specific protocol, late phase, where you can really, even in low flow LAAs, exclude thrombus. There's a very high negative predictive value for that.
Ross, can you just show us the HD grid signals at the beginning of your ablation and where we're at now, just to give us a comparison of what we're looking at?
Yeah, did we save that on the BARD, guys? I would like to pretend it was very difficult, but the truth is we worked our way down the posterior wall, and these massive signals slowed and disappeared for us. So the veins isolated itself despite me, really.
While you're pulling this up, Ross, may I ask?
See the electrogram out there? Well, Mikey, do you want to show us
a
screen with...
May I ask, so when we feel that PVI is the mainstay of therapy, even in long-standing persistent, I mean, I do appreciate that big boys like ourselves need big toys, and I do think the HG Grid's a terrific device for that. But what's the added value in a first-round procedure like this one compared to a standard circular mapping catheter?
Yeah, that's a very good question. I suppose it is true that a lot of the evidence backs up PVI alone for a first procedure. I think people are still striving for more, though. I think a lot of people still think that that for certain people where you've done a voltage map and seen lots of scar, that you might choose to go on and do a sort of more customized approach based on that. I think the signals on the grid are fairly impressive as well, and I think the way it's filtered through the system really does show you very different signals to what I'm used to seeing on BARD. So it is quite often that you'll see nothing at all on BARD and see some really interesting sort of long fractionated low voltage potentials and things. I think a lot of grid users will tell you that if they've found very interesting things on that, quite often tachycardias and AF and so forth has terminated on those. So I think there's some enthusiasm for trying to customize ablation based on voltage maps and how we perceive scar and the extent of disease and so forth. In the UK, a lot of people do have PVI for the first procedure, particularly using one-shot technologies. I suppose, again, that's partly because the sheer volume that we're trying to get through. But I suppose still sometimes on a case-by-case basis, we will choose to do a sort of 3D mapping approach.
Ross, can I ask, what sort of powers are you using?
45 watts. So I suppose that's moderate power nowadays, isn't it? I think you've had your live case with high power short duration already, haven't you? So this probably looks a lot lower by comparison.
So Ross, you're being very disciplined because there's 3 of the 4 founders of star mapping on the broadcast. I can see Sherry in the background there, who was the young investigator winner a few years ago at HRS.
Yeah. Shall I go
So
PA on the right?
do you want to talk about how the HD grid contributes to that, perhaps?
Yeah, so I suppose I trained mostly at Bart's and for a long time under Richard. And I suppose it's quite fortunate the period that we were doing that was sort of whilst AF ablation was evolving, and I suppose we were quite keen trying to ablate two sinus at that stage, as was sort of popular at the time. And I suppose we developed an approach targeting areas that we thought were consistently leading from sort of multipolar catheters, so like HD grids, but more often pulmonary vein mapping catheters back then. And we essentially tried to automate that through the star mapping. So trying to take lots of signals, whether it's from baskets or other multipolar catheters, and trying to pick out areas that would lead other electrograms most often. So I mean, the grid's an ideal catheter for that sort of thing. I suppose partly because the nice clear signals that you tend to get with it, but also I suppose it meshes very well with the omnipolar mapping and the establishing directions. And I suppose what the company pushes is true. The bipolar blindness, as they've been calling it. The size of electrograms and directionality being very much affected by which way they're moving. Sorry, which way they're moving relative to the bipole. Scrape out one. There you go. Yeah, no, so
I think we saw the pre-ablation
like
grid signals from the left. We saw the pre-ablation signals from the grid, but we didn't see the post-isolation. Can they show us those? And maybe while they're coming up, Hugh, what do you think about unipolar, bipolar, and directionality? Is that still a significant issue for us in electrophysiology?
Oh, I think it's a huge issue. I mean, it's one of the real limitations of our old ways of looking at cafes and fractionated electrograms, and also voltage maps. If you're voltage mapping in AFib and the directional, I mean, the signal amplitude is very much affected by directionality. So I think that's really where a catheter like the HD grid has real potential value. I mean, a lot of this is obviously in evolution. I think we've been disappointed with every negative persistent trial, like the DCAF study that tries to do more, great hypothesis, but it came up empty. The AMAZE study came up empty. So we got to keep working to do better. And I think we need more data about these other techniques other than focusing on the pulmonary veins for first ablation and the posterior wall for redos.
And I go straight PA on the left now, shall I? Thanks.
Ross, the guy's able to show us those blood electrograms. Oh, here we are.
No, go ahead, Ross.
Sorry, yeah, there's some very small electrograms there on the pulmonary vein mapping catheter, which again have just disappeared, but I think that must be a deep breath or something, I think. It's too early. Okay, there you go. So I pull back just a little bit. Some fairly fast signals there
so
in the right upper intermittently, actually.
We were looking at the review screen, Ross, of the BARD. I think they were trying to show us the post-ablation left pulmonary veins.
Yeah, that was... Oh, seems to have disappeared. Oh, there you go. That was the left upper post PVI station. Was that what you were after seeing?
Right.
Yeah, so again, pretty silent.
Yeah, and you said you were going to, you had something to add.
No, I'm sorry. I didn't want to interrupt. I was just going to add on and wanted to echo what Hugh was saying earlier, because I think these technologies, I mean, we all love them and we all want to embark on them. But I think before we embark on them on a large scale, I think we do need to do the trials, and we must not also, for that matter, not let the industry off the hook. I think we need to have good outcome trials. And we should not probably, I mean, BART's obviously a huge center with a lot of experience, a lot of protocols, and that's terrific, right? But if these technologies then kind of kind of diffuse into all also smaller centers and are just being used without any real outcome data to back them up, I think it becomes problematic. So I think it's up to us to fill this and to catch up in terms of data with the technology as it is emerging.
But it's fascinating. It's a mark of our desperation that literally every faculty member has mentioned doing something other than pulmonary veins, posterior box isolation, when we still really don't know what to do. It's a big challenge.
Ross, may I ask what the strategy is here? Are you just aiming to isolate the pulmonary veins, or are you going to consider any other lesions outside of that?
Horses for courses, yeah. I was intending to isolate the veins and then see how the cycle length everywhere looked. Again, obviously you don't get to see voltage maps and things until you've started the case. I mean, there are some quite discrete areas of low voltage with sort of fast and fractionated signals. I thought I would finish this and then would go around and have a look at those again with the HD grid, see if those areas still looked interesting. And if they were, I'd think about modifying those low voltage zones. And I suppose, again, one can do it sort of guided by activation, which is possibly the novel part of the work that we've been doing through STAR.
Ross, can you summarize the results of your STAR trial, or the results you're getting using this, your mapping strategy you're using in this case? You obviously are using it because you think it makes a difference, but can you summarize the data that supports it, or is it just your impression?
So for STAR mapping, we did a group of consecutive patients using basket mapping with this mapping protocol. And after pulmonary vein isolation, we go around targeting what seem to be drivers based on activation sequences. I think it was something like 80% of them terminated, and a similar proportion stayed in sinus rhythm for quite a long period. And we then repeated that using, it was using CARTO at the time, so that was done with a pentarray, and seemed to be able to reduce pretty much identical results using the pentarray. So we've moved on past that and been planning sort of subsequent studies, but we've been partnering with the larger 3D mapping companies. So there's something in progress preparing a version of STAR that will be compatible with EnSite. The intention being to allow people to use that and run their own independent studies using EnSite and STAR mapping. However, that is still in development, so that's not what we're looking at today. This is, so far, this is pulmonary vein isolation using EnSite X and nothing other than that. But I suppose I will hopefully give you we've just isolated the vein there. So F7 and drag back for you to have a look.
Let's see the bar.
Can I ask you a question? Given that if we're just isolating the pulmonary vein, what's your view about using cryoablation in these cases for persistent AF?
Cryoablation is very good. We use an awful lot of it, and I've got nothing against cryoablation. I think it's a little bit horses for courses, and I suppose there's some patients, particularly paroxysmal AFs and things, that we expect to do nothing else for. Can we can I have an RAO on the left?
I mean, to answer your question,
a 3D map. Sorry, go on.
Sorry, Ross. To answer your question, Aldo, I think that
it gives you a little bit of flexibility.
The results of the cryo it's so easy and straightforward to use, and if you're just going to isolate the pulmonary veins, I would agree that's entirely, a single shot device, whatever you prefer, would be a great option. But we're falling into the trap of the approach that we use, the technique we use, we're so convinced by. We think that does better than just isolating the pulmonary veins. But as you've all pointed out, it's important that is proved, or at least the individual is satisfied that that's really true. And we've fallen into the trap of this that STAR AF showed very nicely, that whatever we do doesn't seem to improve outcomes at the moment. Unfortunately, I think we were planning to do a multi-center trial examining some of these technologies like STAR, and COVID got in the way and stopped us. So you know, I think your point is well made that good data is still really critical. Hugh, we've been asked by the audience, what do you think is the future solution for persistent AF, which I guess shows how much higher esteem you're held than any of us by the audience.
No, when I think about persistent AFib, I think about all the work that the group in Bordeaux did with a stepwise approach we're all familiar with, where they would show these cases at all the meetings of slowing and termination and ablating to termination. And then when you look at the long-term outcomes, they really were poor. And, you know, Pierre at the Boston AFib meeting basically said, looking back on it, it was all a big mistake. And here's such a fantastic center, you know, going down this blind alley without doing careful studies to prove it really makes a difference. So I think, like all of us, like to be data driven, and I just watched the studies come out, and the only studies so far with persistent or longstanding persistent are the Converge study with the Converge procedure, which is a hybrid procedure with posterior wall isolation, and then there's a small study with the Vena Marshall. So I think it's critical to do more studies. I really was hopeful the AMAZE study was going to show the appendage was going to make a difference, and I was hopeful that DCAF was going to be positive and make a difference. I was hopeful that the TOPERA system would make a difference, but again, they're all negative. So at the end of the day, I suspect where we're going to land is probably with electroporation as the energy source, with PVI, posterior wall isolation, and we need some better understanding of the mechanisms of AFib. I still think the autonomics may play a really important role. Sonny Jackman tends to be right about a lot of things. So I think we need to keep our eyes open about autonomics. But I also think it's about timing. If you ablate early in AFib with small atria, patients are going to do well. And we all know once you have an 8-centimeter atrium full of scar, you can do whatever you want. It's not going to work. And so I think the whole key is going to be getting to them early, before you get all this substrate remodeling, where I don't want to say it's hopeless, but is the effort worth the results? I think that's yet to be determined. But
yeah, that's a great answer. And Aldo, do you think that? Sorry, Ross, did you want to butt in there?
Yeah, I was only going to say, we've had looks like it's terminated to ATAC. I was just wondering if that weighs in on people's feelings about sort of PVI alone for first procedures and things. I think you never really know, do you, if it's a cryo, if we're terminated to an ATAC, should you regard that as iatrogenic and just cardiovert? But I suppose it is one of the nice things about RF, and I didn't plan this, I didn't know it'd terminate to an ATAC. But I suppose it does allow you to map and ablate these, and does make you feel like maybe you've done a more complete job.
Okay, well, that's a great question. So let me ask the panel, you know, is this iatrogenic, or is this a phenomenon of debulking with the pulmonary veins? Yeah, maybe you can start with that one.
It's obviously a very good question. I would first go back and see if that patient has had that before clinically. So if they've always been an AFib, or whether there has been some recordings at least of some regular tachycardias, obviously acknowledging that by the time that they've had their ECG done, they may have converted from that regular tachycardia into AF with the pulmonary veins connected. So if it was really regular, completely stable, not changing a pattern every 2 seconds, I probably would go and hunt this down after successful PVI. And I fully agree, of course, with what Ross said. That is one of the advantages over a simple single-shot device.
Sorry, doing very well.
What do you think, Aldo? Is this iatrogenic or debulking?
I don't know is the answer, Richard. But I would agree with Ross's strategy that if you get a stable tachycardia after pulmonary vein isolation, it seems entirely reasonable to then map that and try to terminate the tachycardia.
It's quite interesting. We don't often see this happening after cryoablation. Is that because of the size of the lesions, or what do you think the explanation for that is?
Well, I mean, we may be selecting patients for cryoablation that have smaller atria, less scar, more paroxysmal, early persistent. So it may be more of a bias that we tend to use RF when we think the atrium's going to be big and whatever. So that certainly is a possibility. But the idea that it's iatrogenic isn't impossible. And I mean, the thing that I'm struck with Ross's response is this is the approach that Bordeaux was using in the stepwise approach. They turn it into an atrial TAC, ablate the atrial TAC, terminate it. But at the end of the day, the results were not at all impressive. They were poor. So we feel better, and everyone feels like you do more. But again, I'd like to believe you. It's like a quote Al Waldo told me once at an FDA meeting. I'd like to believe you, but show me the data.
Yeah, although to be fair, the stepwise approach achieved ATAC by non-PVI ablation. So we're still at a very early stage of this case. So I think it would be, would you not stop? Would you stop now after isolation of the pulmonary veins?
Oh, no, I agree. When you have RF in there, I would definitely chase down any flutters you got and try to terminate them. I agree completely. But if you're using the cryoballoon, I wouldn't necessarily pull out an RF catheter. I'd cardiovert and see how the patient does and address it in a second procedure if needed.
Okay. Ross, what are you going to do next?
Yeah. I'm just finishing the line, like we discussed whether we should or shouldn't, but I think we're just about done with that anyway. I've cheated and looked at the ECG, and I thought a little bit suspicious of flutter, so I was mulling over the idea of pulling across and seeing how it looked on the CTI, see if it's ahead of the CS proximal, maybe entrain from there perhaps. I suppose we've got a little bit of time left. Maybe I'll do shall I set up for a map? Shall I map off the CS and I'll use the grid? So I'll do a little map of the left atrium using the grid.
Yeah, great. Okay. And while you're doing that, I would like to propose to the panel that one of the reasons that we may see more organization is because the encirclements produced by radiofrequency are larger than they are with one-shot techniques. Am I being excessively controversial here? Maybe ask Jan first.
No, I think that's perfect. In my eyes, perfectly reasonable way of thinking about this. I fully agree.
And Hugh, what's your thoughts about the size of the wide encirclement that's enclosed?
Oh, I agree that with a balloon-based technology, you end up being more osteal. And we always get a CT in advance. And when you look at the CT, you can see where the actual antrum plugs into the posterior wall. And we all see these common atria. I tell the fellows it's like a pair of blue jeans. You got the legs, and then you got the seat of the blue jeans, and where's the waist? And if you say we want to incorporate all the antral tissue, much of that, it's like Andrea Vitale's been telling us, is the whole posterior wall is really antral tissue. So I think when we go in there and ablate the veins and the posterior wall, oftentimes it's all this the more osteal part of the vein. So I agree that the balloon-based technology, you're much more distal, and that's why I always use RF for a second procedure so I can get a much more broad accompaniment of the antrum.
So let me ask you
so
then,
Ross,
Hugh,
we've
when
got
you do a redo procedure, then I apologize. Hugh, maybe a follow-up.
Sorry, Jan, let me just go back to Ross.
Into your main job.
Ross, sorry, I just want you to explain to the fellows that may be watching what you're up to now.
And say that again, sorry?
I just want you to describe to the fellows what's happening.
Yeah, so if you're looking at the decapolar catheter, the green one at the bottom of the live electrogram screen, you see the CS going proximal to distal. The CS has been fighting a little bit, so I think it's hanging out a little bit, but it's essentially in the CS, or at least the distal 2/3. So I've been doing a map sort of all over the left atrium, but I suppose the quick and cheating version is to have a quick look and see what the anterior wall is doing, because if both the anterior wall and the posterior wall are both going septum to lateral, then really that suggests it's coming either from the septum or coming from the right atrium. So I suppose it's also one of the omnipolar map that has a second sort of sense check on it. So you can see the little arrows running everywhere. So on each beat, it'll give you its own appraisal of the directionality of flow. So use a combination of sort of unipolar electrograms and bipolar electrograms. Oh, sorry, I forget you've had a talk on this yesterday, haven't you? But again, I suppose compatible with the colors from the activation map, it's suggesting that the impulse is going septal to lateral again. And it's about on time with the proximal CS as well there, which would again be compatible with flutter. So I think I'm going to park this in the left atrial appendage, or will I? And then I'm going to take the map catheter back to the right atrium and have a look to see if we think that's part there in the left upper. Okay, so putting back my map catheter now. So I'll come out to the cava tricuspid isthmus line. Do you want to? Oh yeah, we made a brief right atrial geometry first just to show up our CS. Can we put our map signals between the HD grid and the Deca?
Let's see the bar so that you can describe to the fellows what's going on.
You wouldn't fix my earpiece again, would you? Sorry, so the electrograms on the CTI a little ahead of the proximal CS, and again very suspicious for...
Ross, we need... yeah, we go.
Oh, sorry, I lost my sound for a second. We off in conversation. Should we entrain here in a minute? So I'm fairly sure we're going to ablate a CTI line now, but maybe should we entrain just to convince the audience perhaps? So should we come on at 220 or so? Yeah. Maybe I've not got a great position because we're not really capturing there. Got poor contact, haven't I? Do you want to try again there? Got a bit better contact. Looks like we had it right at the end there, didn't we? Could I have a LAO and RAO? Okay, so
can we see the signals, Ross? Did it in train?
Page. Yeah,
we need the review screen.
You're able to look at the electrogram page for us? And can I have an LAO on the right on the Insight? So you can see that's accelerated from the CS electrograms. Do you want to measure that again for us in real time so the guys can see for us? So they're moving the calipers along to show that we've entrained. We're pacing at 220, then measuring the return cycle length there, and then carrying that back onto the return cycle length. And we thought 20, 30 odd. So counting for my catheter misplacement, that's it's probably compatible with flutter, isn't it? So I'm going to line up now for a flutter line.
So Jan was about to say something, but before he does, we got a question from the audience, which was when you ablate the right inferior pulmonary vein, why don't you place the grid in this vein and keep it in the right superior? And I think the answer is because you're doing both together as a wide encirclement. So as long as you've isolated the right upper, you've isolated the right lower. Jan, you were going to say something earlier on.
Now, just thinking about the right atrium now, obviously outside of the atrial flutter, I was just going to ask you, Richard, also Ross, and obviously also Hugh and Aldo, ultimately, if you want to chip in, you know, what patients are you thinking about the right side? Obviously, except the CTI. Vena cava, supravena cava. What's your thoughts in persistent reduce on the right side of lesions?
Yeah, years ago, I was enamored with the SVC isolation and thought that may be of value, but over time, I found it disappointing and no longer pursue that. the non-pulmonary vein trigger stuff, we don't see in Baltimore. We go high to high dose isoproterenol. I don't see firing from other non-pulmonary vein sites. But I think the real thing that bothers me is some patients we see have a small left atrium and a big right atrium. And I can't help but think that in those patients, we need to be doing something in the right atrium. But as of yet, I haven't figured out what it is and I haven't done it. But I think we need to pay more attention to the right atrium, which may explain some of our failures when we get nice pulmonary vein isolation. But in these, particularly in the ones with a really big right atrium, out of proportion left atrium, I don't know what causes that, but I think there's a subset of patients where it's got to be in the right atrium, and we currently are doing nothing at Hopkins about that.
I would agree with you that the right atrium is really rarely an issue. If you do see termination, it's around the CS or the mid-isthmus, but I think unless it's a very dilated atria, it's not often involved. And the SVC isolation I do as an act of desperation if all the pulmonary veins are isolated and they've still got paroxysmal AF. And occasionally it does work, but I don't do it as a routine as my first process. What about you, Aldo?
Yeah, Richard, I completely agree. I mean, we don't perform SVC isolation routinely. So I'd agree with everything that's been said. Just a comment, a question in terms of practice at Barts for these patients. What sort of pre-procedural imaging to look at substrate do you do? Do you use MRI to look for scar pre-procedure to guide whether or not you do an ablation or how you do the ablation?
Should I take that, Rich? We don't do MR imaging unless it's for another reason, so for ischemia or something else. People would have an echo, and that's pretty much it, really. Everything else would be case-specific or to look for something else. We won't do anything else to guide the AF ablation, so we don't do image segmentation or trying to look at scar. Again, not 100% sure of the place for it, I suppose, much as we're criticising whether one ought to do much beyond PVI. I suppose one could view sort of imaging in the same way, really. How much bang for your buck do you get?
Could we ask the other panel
Ross, we were asked...
Sorry?
Let me just quickly ask Ross, we were asked, why didn't you map the right atrium with the grid?
I suppose I could have done. I've got my nice left atrial access for the moment. I suppose fairly confident this is going to be CTI dependent. I suppose to do that, I would have to take the one sheath back, take the HD grid to map the right atrium, then switch over sheaths and take the map catheter out to ablate it. And I suppose it's just not very convenient for sort of workflow and things, really. I mean, it's true, if I'd seen a tachycardia coming from the left atrium, I wouldn't just immediately go and ablate the roof or something. But I think in the right atrium, the stats are so extraordinarily on your side. And I suppose that goes strongly in our favour there. It's just terminated. There's no cardioversion when you weren't looking.
Well done.
Yeah, I think if the activation's suggestive of it in the left atrium, if the signals in the right atrium suggest that you're just ahead of the coronary sinus catheter, and I think if you're entrained from the CTI, I think, to be honest, that's much more than I would have done normally, really. Is that how do
Ross,
others
can you
feel
show
about
us
that?
the BARD signals?
Oh, sorry, would you guys be able to show us the BARD signals on termination? Yeah, if you could just maybe bring that review screen over for us.
And while that's coming up, Hugh, what do you do about pre-procedural imaging?
So our routine is we get CTs and everybody, as we said before, to screen the appendage. And I love looking at the anatomy in terms of where the pulmonary veins really plug in and how big is the atrium. We have a CT scanner across in the EP lab, so it's no big deal. It takes 5 minutes. So that's what we do. We used to get a lot of MRI, but it's become very difficult to get the scans done in COVID. There's short staffing and so forth. And the advantage of being able to skip the TE is wonderful. So that's what we've done.
And Ross, have you got
Yeah, I'm
bidirectional?
using it
Have you got
instead of a
conduction
TOE
blocks
spray
through the
knife.
isthmus yet?
I haven't assessed yet. I was just polishing my line first, but yeah, I do intend to check for that in a second. Yeah, I tend to track back along my line at least once, just to make sure I've given it a fair pasting before I check. It's very
Can we
dull
see
to
the
check more
live
than
barred
once.
signals?
Oh yeah. Can we switch them around to see the live barred signals again?
And Aldo, what about you with pre-procedural
So,
imaging?
yeah,
We tend to use a lot of MRI, Richard, rightly or wrongly. I mean, we do sometimes base decisions on the basis of the left atrial size and the presence of scar. I think Dr. Calkins earlier mentioned the use of hybrid surgical approaches, and that was going to be one of my questions. In this group of patients, is there a cutoff in terms of the longevity of the atrial fibrillation or the atrial dimensions in which you would consider either not undertaking an ablation or considering a hybrid type of ablation?
sorry, was that to me?
Yes.
To you,
I mean, I'll
Richard.
just answer that, you know,
I
for
was going to
us,
say the statistics are. Sorry, you guys carry on.
our approach is regardless of the size, you know, to do an initial ablation procedure, but our prediction are when we talk to patients about the expected success rate, it will vary depending on how big their atrium is and how long they've been in continuous AFib. I think that's critically important as a prediction. You know, the conversion procedure, I think, is a very attractive procedure. Currently, it's not being done at Hopkins, so that's not an easy option for us to pursue. So, you know, that's why, you know, we tend to go with catheter ablation first.
Yeah, and we were asked by the audience about empiric CTI lines in persistent AF. Is that something that you ever do, even if they don't have documented flutter?
Well, you know, I think particularly in redo cases, I think I personally have a very low threshold to go for CTI, for empiric CTI in redo cases, because as we all know, the co-prevalence is just so high, and quite frequently we just simply don't catch the flutter, the CTI, the isthmus-dependent flutter, and they just reappear with AFib. So I think my personal threshold for that is pretty low. Although, again, if we take a look at the data, it's not really all that convincing. But I mean, once we're there and once we're really thinking about redoing, again, transeptal, again, left-sided ablation, I think the add-on risk that you add to the procedure is actually quite low. So that's why I tend to do it.
But I agree, for a first procedure, there's really no data supporting it, so I wouldn't do it for a first procedure, but I agree for a second procedure, you have a lower threshold to do, you know, a lot of additional things.
Yeah, so tell us what's happening, Ross.
So I'm just checking CTI block. I think we just checked right next to the line. I think, was it 176? Is that right? In fact, I'll tell you, are you able to see the live screen there?
Yeah.
You got the live screen. Okay, so I'll try and show you. Okay, so that's. Sorry, I've got an invisible geometry at the moment, but I think that's probably about 9 o'clock on the geometry. So should we measure that, guys? So what's that? 165 maybe. And then I'll try come down right next to the line. Let's keep that in there. Okay, so there. Great. Bit mobile then. 190 right next to the line. Should we pace off the map? So we're going to pace off the map catheter now. Show bidirectional block. Okay. Should we stim to 910, I guess, 195. So that's looking pretty good for bidirectional block, isn't it? And there. Okay, should we stop pacing there? So at this point, I would go on and check the veins, and I would ordinarily be done really for a persistent AF. I suppose could make arguments about giving adenosine and things, or isoprenaline. Do people on the panel do that at all? Should I go back to, should I go PA and left lateral?
Jan, do you give adenosine?
No, we don't. Also based on the negative results from the trials, really. Well, we do waiting times though, and I was going to ask Ross, you, what about especially in redo cases? Do you do waiting times? How long are they before you pull back?
Yeah, I suppose it depends a little bit on what we find and what else we've done. So I suppose, I think we started the case about 5:45, so we've been going just over, or coming up an hour and a half or so. So I suppose we isolated the left veins, must be a good 45 minutes ago maybe. And I suppose even the right veins, by the time we've done our mapping and our CTI, I suppose I would argue that we've done a little waiting period already maybe. So do you want to F7 that? I think I would say that all looks very far field. Shall I see if I can, do you want to show me an RA on the right? If I can pick back across easily to paste the appendage, I will, but maybe I won't fight for it.
No, I'll just
So maybe we can see the signals as well.
That I agree with Jan that we don't give adenosine or isoprel at the end. I mean, I think you know, with modern ways of delivering RF energy with different formula-based approaches, I think the recurrence rates are so low that I generally don't routinely have a waiting phase. Certainly for first-time procedures, I isolate the veins and get out of there. And you know, I just think we're much better at creating lesions with our different ways of delivering RF we have now.
So I've picked the map catheter back over and I'm just going to stick that in the appendage to, maybe it's overkill, but I was going to paste the appendage and hopefully show that far-fieldy looking
signal. We see the signals, Ross.
Yeah, so should we go back to the live screen? No, should we paste from the map in a second? So are you guys seeing the electrogram page now? So we have the grid in the left upper pulmonary vein. I'm pasting the map just because there was a sort of far-fieldish signal there. I can't see any sharp signal separating out from that. So I suppose I would argue that whatever we were seeing there must have been appendage. Do you want to stop pasting there? I think it was fairly far field anyway. I'm not sure everyone would worry about pasting the appendage, but...
Ross, I have a question for you.
Yeah.
The question is, do you use esophageal temperature monitoring or not? Or what do you do to avoid esophageal injury?
We don't know. So I suppose another thing is they're under sedation. So I suppose if people are feeling a lot of pain, they tend to move. I suppose a lot of the data for fistulas may be linked to TOE. Can I have a PA on the left? Yeah, but essentially we don't monitor the esophagus. I suppose it can be done, but it's not an easy thing to do under sedation. There is some data. I was lucky enough to be part of a study with the Oxford group looking at use of higher powers and LSI and esophageal temperature alerts. They did a small randomized study of 80 patients, and really they had no more in the way of high temperature esophageal alerts with 40 watts than I think it was 25 watts was the comparator group. So I know it's all still very controversial, I know, but I suppose our practice is not to use esophageal temperature monitoring for cryo or RF for that matter. So that's the left lower that we're in there.
And is that sort of pretty standard in the UK that temperature monitoring is not done? Because in the US, as far as I know, everyone does it. It's sort of a standard here.
That's true. It's almost nowhere in the UK is esophageal temperature monitoring done. Yeah, they were aware that it's a sort of a difference in practice in the US.
Any randomized studies showing that it reduces esophageal lesions, Hugh?
No, there's no, as you know, there's no randomized data. It just makes you feel better if you get an atrial esophageal fistula, which I never have in one of my patients, but you feel better if you used it.
Yeah, please God, neither have I.
Yeah, okay.
Yeah. Do you guys use PPIs, I suppose, is another thing?
Always.
Well, I might have lost my audio there. Do you guys use PPIs?
Oh, yes.
Yeah, no,
Yes.
everyone says always, yeah.
Okay. Yeah, I suppose again we've only just started doing that here at Barts, but maybe we were just slow to catch on with that, perhaps.
So we were asked by
so
a
it's
question
right
by the
lower
audience, Ross.
Yeah.
Do you look for exit block also from the
That's pretty good
veins?
there. Yeah, sometimes I'm more diligent than others. We could do. Should we pace around that now and see if we can demonstrate exit block? Should we pace around the HD grid? I think showing capture of the pulmonary vein sleeves is really great if you haven't seen the veins go or if you're in any doubt. But I think where we've been lucky enough to see them go first pass isolation on both sides, I think we'd be very unlucky if this weren't isolated, if it looked quiet. We are pacing around it now. Are you guys getting to see the live screen there? The live electrogram screen, sorry?
Yeah.
Okay.
And is that local capture or is that just artifact?
I'm not sure. I was betting artifact, but it could be.
Well, we're coming towards the end of the session, Ross. You said you were lucky to get first pass isolation, but I think that Gary Player once said that the more he plays, the luckier he gets. So I think that that's probably true here as well. We were asked how quickly can you get through a case like this, thinking versus QDOT versus cryo, and I think you've answered that question quite nicely as well. Any last comments from any of our faculty?
See where that will speed things up.
No, I would just congratulate Ross for a beautiful case, and doing it on live screen is heavy pressure, and it was wonderful. So thank you so much.
Likewise, well done, Ross.
And so do I. Obviously, let me chime in, but with one word of caution, just because you were mentioning earlier, there's also a lot of maybe fellows watching. Speed is always good. It's nice to have low dwell times also for the patient, but especially during your first couple hundred cases, don't go for speed as the primary goal. Needs to be safe primarily.
Great. Well, I'd like to thank the panelists, Hugh Calkins, Aldo Rinaldo and Jan Steffel. I'd also like to thank Ross, Sherry and the team at St. Bart's. Join us next and for the next and final session of this year's Rhythm Intervention Online 2021. We'll be discussing the future applications of leadless CRT pacing. See you there.